is on amblyopia is beyond barrier. So just before starting, so I would like to ask, so what is amblyopia? I think we all of you generally call it is a lazy eye, right?
Yes, sir.
So is it lazy eye? What do you think?
More than that.
It's not lazy eye at all. It's a false. So amblyopia is basically is on the brain, not in the eye. You know, we have a three gates of amblyopia. That is the SMP, simultaneous macular perception, then fusion, and the stereopsis. So only camera is captured the image, and rest of the things is happening in the brain. So that's why amblyopia is in the brain, not in the eye. And if you see in amblyopic patient, especially in refractive amblyopia or strabismic amblyopia, if you see the retina and photoreceptor, all everything is normal. So amblyopia, nothing happens in the eye. So only eye is the sufferer. Now, second query: is amblyopia is possible to treat after 12 years? Yes or no? Yes. So this is also false. Yes, amblyopia can treat at any age. So there is no scientific study, either ophthalmological or optometrical, to show that this is a true. Whereas there is a lot of good studies there where it can be shown that amblyopia can be treated at any age. So a lot of neuroplasticity study is there. You know, this study is 2005, and this is what they are concluding. You just see, neural wiring in visual system is not dismantled by visual deprivation. Neural wiring is the visual system is merely deactivated. Neural wiring is capable of being rapidly restored. And they have concluded and suggested that allowing children with amblyopia to use this both eye rather than the patching in the stronger eye, that enables better recovery. One more study that is from the optometry background, they have concluded that lenses, occlusion, and active vision therapy can be a good, you can say is a treatment protocol for amblyopia therapy at any age. Now, what is the definition of amblyopia? Generally, we know we are used to say a two-line difference in both eyes, so we call it amblyopia. But the recent definition of amblyopia is a function of amblyopia is can be unilateral or bilateral, where the visual acuity is less than 6.6 or 20 by 20, and there is no structural, no psychological, no other pathological abnormality is there, and most importantly, amblyopia is occurred before 6 years. What is the behavioral definition? So like we have a two eye, so both eyes capturing the image. So when the different of two eyes happening or any competition is happening, so that then amblyopia can be happening. So our two eye is like a one mother's, the two babies there. So one mother is giving messages to same messages or same culture or whatever you can say to giving giving to the same child by the same mothers, and you see what is happening. So they are learning the same things like a two eyes, but if they have a different, means let's say one eye is plano, another eye is +5, or one eye is plano, another eye is -4. So this type of difference is there, or maybe some clarity difference is there, or other differences there. So that times, so mainly one will suppress on other, and that will lead to a dominant on each other, and finally it's lead to a suppression, and ultimately the patient will can be a amblyopia. So amblyopia, as I told you, amblyopia is not in the brain, not in the eye. Now we'll come to the types of amblyopia. Basically, broadly, these four types we see. That is most common. That is the refractive amblyopia. It can be isometric. It can be anisometric. Strabismic amblyopia, image deprivation amblyopia, and organic amblyopia. Sometimes we see. Then what happened in the eye? So some visual abilities, or you can say, as I told you, yes, eye is the only the sufferer. So what are the visual abilities? The problem is happening. We'll see they have a problem in their fixation. The most likely, if you see the suppressed eye, if you see the how many you do the visioscope, in the ophthalmoscope there is a target is there. If you see through this, you will see in maximum, amblyopia, what I have seen in my clinical practice, they have a eccentric or eccentric fixation is there in the suppressed eye. Third, you will get, latency of eye-hand coordination. You will get decreased pursuit accuracy, accommodative skills, amplitude, and latency of the accommodation also. Along with that, you will see poor discrimination. If you see the visual perception, you will get lot of poor discrimination is there, spatial certainty is there, continued interaction problem is there, which is lead to your crowding phenomena, and also which generally we don't check that is called visual information process speed and ability also reduced. Now some basic examination, like if you see any amblyopic patient, what are the basic examination you will do? That is, definitely we'll see the distance and near visual acuity. Pinhole also require. Refraction will be a different, that I will tell you later on in the management part. That is in monocular fixation, in binocular field. Like I'll tell you how to do the refraction in amblyopic patients, something differently. Then you can check a Bruckner test. You see which eye is amblyopic eye. You will see a little bit brighter reflex on that eye. Oculomotor you will see the second and pursuit. You have to just see like patient have to fixate from here to here, how they are fixating from one object to another object. And as I told you that you have to see very carefully the macular fixation. Why this is important, and most of the, I am not against any software or anything. Even I am also using some different software. The patient, if patient have a macular eccentricity or anomalies corresponding point is there, no software is going to work. So only we have to break that eccentricity and anomalies corresponding point, then your amblyopic, visual acuity will improve, your stereopsis will improve. Then you have to see Watford dot. So generally we see Watford dot in distance as nearest, but we see in dynamic condition. Dynamic means how we'll see when patient is working, I will see how the patient is, Watford dot is there. If patient is moving, patient is stretching their hand, how the Watford dot is there. That is very important because as a human being, we are not static, we are all the time a dynamic. Stereopsis, in the stereopsis generally, we say, if we check the stereopsis is two type of stereopsis. One is the local stereopsis, another is the global stereopsis. So generally what we see, that is a local stereopsis, and we write, the amblyopic patient or any strabismic patient is there, patient is not able to even identify the first target. Like if you see the target, so what we write, generally we write the patient stereopsis is absent. Stereopsis is not absent at all. Maybe what you are checking, that is a local stereopsis, that is a global stereopsis. So you have to use local stereopsis is a range around 25 to 400 to 800 maximum, not more than that. Whereas the rando stereopsis, which is global stereopsis, which check the central and the peripheral also, so that is from 25 to 2000 second of arc. So stereopsis is there, that is you have to be kept in mind. So, but maybe you have to see with the other method. So definitely, as a eye health, you have to see with the ophthalmoscope, in the slit lamp, visual field, whatever you require, the general examination. Amblyopia sometimes is required. Now we'll come to our treatment option. The treatment option. So total occlusion versus full prescription. How will prescribe? I would like to know from the practitioner. I have no lot of practitioners here. I'll just like to know, like, what you do generally if you see any patient of amblyopia. Anyone? Just please share your, how the experience, what you do if you see any amblyopic patient. You do patching?
Firstly, initially, we'll go for the patching, the good eye to be patched and the worse eye to be work better in its way.
Okay. So what type of patching, sir, you give?
Giving
it's like a full patch.
Yeah, full patch.
Right. Okay. So total occlusion, why I've kept it like this is like what we are treating as a, and that is more successful result we are getting, that no occlusion or maybe a partial occlusion. I'll tell you why and what. And the active vision therapy definitely it will help, and sometimes you have to prescribe the glasses also. That is also be helpful. Now I'll come to your point. If I do a full patching, then why you are not recommending for the full patch? If I do a full patch, a patient, so our vision is a two pathway. mainly three pathways is there, but broadly you are categorized in two pathway, parvocellular and macrocellular, central pathway and peripheral pathway. So a patient is amblyopic patient, already the central pathway is affected, and what you are doing, you are giving a full patching to the patient. There's a lot of compliance study of amblyopia is there. If you see, the 1,000 studies that of compliance on occlusion, because children, they don't want to do a full patch. I know, I think all of you experience about that also. So why? They have their sport activity, they have their academics, they have their other activities there. So what you are doing, and if you are closing the full patch, so you are closing the central pathway as well as peripheral pathway. Like yesterday we have discussed about what pathway and where pathway. So what pathway is only to see how much, is only for the identification. Whereas where pathway have lot many functions for a patient is adult, for their driving and other activities, sport activities, so it's very important. So if you do a full patch, so what you are doing, you are closing both pathway. You are closing the where pathway and what pathway both. So they will get more difficulty after doing a full patching. That is the number one. Second, the field is decreased, and as I told you, their life performance and ability will decrease. Sometimes they get double vision also. There's a lot of studies is there. They are recommending, results suggest that the current treatment approach of patching the sighted eye that has been operation from last 300 years may in fact be the strengthening rather than the reducing the binocular imbalance. That characterized by amblyopia. So if you do a full patching, the study, the recent study, they are saying rather than increasing the binocularity, is reduce the binocularity. The another study is from UK. Around 332 children was conducted, and they have assessed, and they have done around 1,238 hours to 2,815 hours of patching, and they have what they have concluded. Although mean duration of treatment was long, involving many hospital visits, the outcome was variable and very unsatisfactory. So full patching is not a good option. Then what to do? So what you have to do? You have to do a partial patching. So partial patching means what? You can use a Bangator filter. So what you have to do? Let's say my right eye is a suppressed eye and my left eye is a non-suppressed eye, right? So what I'll do in non-suppressed eye, what you have to do? You have to just blur two lines. Like let's say left eye is a 6/6 and right eye is a 6/60. So the left eye is just reducing two line of the visual activity. Let's say it was 6/6. Now what you are doing? We are doing up to 6/12 with the help of the filter. So what is the benefit of that? You are not closing the wire pathway. So only you are blocking the what pathway, means central pathway. So only little bit visual acuity would deteriorate, but patient can do their whatever activity is there, like a sport activity or academics or other things, they can do very well. Now, if I come to a treatment purpose, so what is the key concept is that neuroplasticity is a process by which neurons can increase their connection with other neurons through sensory stimulation, learning and experience. So what is the therapy? So when you do the therapy, so you have to be think about that, about the stimulation, learning and experience. So experience, whenever we see something new experience, so in our brain, the neural connection is spread. Like if you don't know driving, you are trying to learn driving, so you are something, the stimulation or learning something is going, that is increasing your neuroplasticity in brain. So this is a very good study from neuroscience. The principle of neuroscience, that is called the Bible of neuroscience actually. What they have quoted, you just see. Neuroanatomical and neurophysiological changes are constantly occurring in brain. Sometimes it is the creation of new synapses. Sometimes it increase amount of neurotransmitters stored in presynaptic buttons. Sometimes it remodeling, either strengthening or weakening of an existing synapse. That is what makes all new learning is possible. So change is possible, age is not a matter. So in amblyopia or in case of strabismus, you can do it at any age. So the cells have not been destroyed. they are just sleeping and they are ready to wake up. They need a proper care. So what is that care? With a kiss. So what is that kiss? The kiss is behavioral care based vision neuroscience treatment is required. So this is the key to success to amblyopia. The first, that the prescription what we are talking, that is behavioral lens prescription. So what you are going to talk? So I'll just put an example so maybe you can understand better. Let's say one eye is plano, another eye is +5, and one eye is 6/6, another eye is 6/60. So now the question is that how much are you going to prescribe? Will you going to prescribe full prescription? Will you going to prescribe partial prescription? How much? What is the thumb rule? Anyone, sir, audience from? Anyone from audience, sir? Anything? Please. So what you have to do? So if you, rather than prescribe, generally what we do, we are giving the full prescription, right? Plano and +5. Okay. So what will happening? Rather than prescribing plano and prescribing, my refraction will be a MF and BF condition. Means my both eye will be open, and let's say the +5 in my right eye, plano in my left eye, and slowly I'll reduce my this +5 until and unless will check with the fusion and the stereopsis. So which correction, which refraction will give me better fusion and stereopsis? Maybe it can be a +2, or this eye maybe, because this eye is 6/6, so maybe I can put a +0.75, because that nothing is going to happen on that eye. It will be remain 6/6 if I put a +0.5. So what we are trying to do, we are trying to decreasing the anisometropy. As you know, for one diopter anisometropy around 2% anisogony is there. So the first prescription, if you are prescribing plano and +5, so that is how much anisogony is this? Around 10%. So rather than prescribing that, if I am prescribing +0.5 in right eye and the left eye in the +2, if stereopsis or fusion is better, it's not there is no thumb rule on that, right? So wherever the stereopsis and the fusion is better, that prescription we are going to prescribe, right? So here, how much the anisogony is coming? +0.5 and +2. So means 1.5 diopter difference is there. That means in and around 3% anisogony is there. So which is what actually we are doing? We are decreasing the binocular competition, which is give the better result. And may you can advise for the contact lens, then it will be more easier. One more important thing, we have to see a dynamic retinoscopy. So we all know about the static retinoscopy. Dynamic retinoscopy, you have to see if any patient there, means it's a near retinoscope, to see the accommodation status of the two eye, and you have to see binocularly. The near target will be there, means the retinoscopy and target should be parallel to of each other. You have to just see either the patient of lack of accommodation or lead of accommodation is there. If you see any type of lead or lack of accommodation is there, you have to prescribe a bifocal glasses, even if patient are in children also. Now we'll talk about the active vision therapy. So what are the purpose of the therapy is that to maximize the patient performance in visual related problem, like as I discussed, patient have a psychic perceived problem, patient have a accommodation problem, patient have a, so we are divided in 3-4 categories. One is the gross motor, second that is called monocular activity, then biocular activity, which is called M.Optom therapy, and finally we can say as a binocular therapy, binocular activity. So we are separated in 3 parts. So what we are doing, changing the neural correction in the brain. Then this is the very good books, you can read about that. To change the wiring in one skill, you must engage in some activity that is unfamiliar. As I told you, like how the neural connection will increase in your brain. Novel to you, but related to that skill, because simply repeating the same activity only maintains already established connection. So if you are doing a patching on every day, the same activity, So that will not increasing the neuroplasticity in brain. So what you have to do, you have to do some activity which is very unfamiliar, and that will increase the neuroplasticity in the brain. So that's why we are talking about the active vision therapy. So the first is, as I told you, monocular means is just increasing the other eye confidence and self-esteem. Second, monocular fixation in binocular field you can call as a engagement, and binocular activity you can call as a marriage. So first you have to work with the specialization, means you have to work on the gross motor. Lot of other things you have to do. You have to work on bilateral integration, like this type of activity. Simply you make a cross in the center, you take a board and give the two marker to like that. Okay, patient have to see in the center and they will circle and circle. Okay. Next, which is very important, that is called synchronic light therapy. So synchronic light therapy is very new to us. We are doing that. So in this is very quite effective also, and Dr. Desh and Friesen, they have got Nobel Prize when they are first they invented and they are treat to lupus. So that time they will come to know about the synchronic light therapy. So how it look like a synchronic light therapy? We have some videos on that. So patient have to just expose of different color of light depend on the condition. Next, next activity that is called monocular activity. So this is for the psychiatric therapy. So patient just have to patient is have to read the first letter from the word and the last letter. Can you see the sound? So you can use the metronome also with the sound. With the sound, patient can read like A, C, K, P, like first word and last word. So what you are doing, we are jumping from this image to this image. Okay. So we are doing a circuit, and also patient is listening with the metronome sound also. Also you can use this type of activity. So you can incorporate with the balance board also to increase the gross motor also. Okay, so patient is on balance board and is rotating, and patient is touching also. So all together we are doing. So other monocular activity is on pursuit. You can see the first one, that is called pegboard. So it's you can use a Marsan ball also. So patient have to just follow that. So this is something called as a BTS4. So you can patient have to just here the full occlusion is not there. Okay. So only a partial occlusion is there. Then some accommodative therapy. If you see it's like a flipper, so you can do for distances also, and you can do for near. So you have to work on the amplitude of the accommodation and the facility of the accommodation. Next step, what I call, that is called engagement, like as I told you. So that is called the monocular fixation in binocular field. So what is that? So some activity. So this is called a bar reader, the first one. So patient have to wear a red green filter, and the strip is there, the bar reader is there. So patient have to just read with a red and green filter. So idea is that, so when patient is seeing from the right eye, so only red patient can see. From the left eye green, patient is only the green one. Right? So rather than doing a close, so what we are doing, we are trying to open what and where pathway both. Similar activity like you can do this way also. So like patient is wearing a red blue filter, and some activity is happening. So patient have a red and blue target is there. the final activity that is called marriage. So that is called a binocular activity. So what are the binocular? What is the goal of the binocular activity? So binocular activity is the goal to maintain the good stereopsis. The patients would have good stereopsis. So generally we see that after patching, the patient visual acuity is improved. That is not the goal. That is not the main outcome. If patient stereopsis is getting better, so means that means your amblyopia is improving. So what is stereopsis? As I told you, like stereopsis have two types, local and global. So stereopsis means solidity of something. It's not just only a depth perception. So some binocular activity, the first that is we call a tanaclef. So patient have to we have to wear a red green filter or red green glasses. So patient, and slowly you have to move it. Patient have to maintain the single. So you can use in same thing in like same random activity, that is also for base invasive out therapy, that is also for convergence and divergence, and also you can improve the vergence facility. This is a bundloscope, so you can do with same training with the convergence and divergence training. This is a Broxting activity. So these are the few binocular activity. So conclusion. So conclusion is, don't forget to treat whole child or whole adult. You are not treating amblyopia. You are treating a person with amblyopia. You also may need to work on the learning problem, bilateral integration problem, or perceptual problem. Thank you so much. If you have any query,